All right, welcome to today's RISE webinar on population health management. We appreciate you spending your lunch with us today. We'll start in a few minutes once people have had a chance to sign on. My name is Leslie McGeo and I will be your host for today's webinar. I'm a focal point with RISE and I work for Trillium Health Partners. Today's webinar is about population health management, a core concept for Ontario health teams. We used your feedback to develop today's session and heard how many of you would like to understand how to apply an equity lens when caring for your population. We also heard from OHTs that you want to continue developing connections and sharing ideas with one another. So as you join the webinar today, please enter your name and introduce yourself in the chat box, your organization or OHT. Ensure you select all panelists and attendees so we can all see who's joining. My colleague at RISE, Steve Lott, is also supporting us behind the scenes to ensure that things run smoothly. If you have issues with Zoom, you can message the host and he can help you resolve them. Hi, Melissa. Welcome from Chatham Kent OHT. Nice to see you. Hi, Denise, Alzheimer's Society. Hi, Christina, one of our population health management coaches. And Donna from Region of Peel. Amber from London Middlesex Western OHT. Megan from Alliance for Healthier Communities, Christina, another coach, Kate from Mississauga OHT, welcome, Leslie from Ottawa, welcome, Anne-Marie, thank you for joining us today. Wow, they're coming in faster than I can read them out. Welcome everyone, we're so happy you can join us. I'd also like to welcome Cynthia Damba from Ontario Health, who will share with us examples of using data to understand inequities in care. Welcome, Cynthia. We're also very lucky to have Sophia Ikra and Zuar Patel from Health Commons Solutions, who will show us how to use asset mapping to map your resources and learn more about your communities. Welcome, Sophia and Zuar. And welcome to Betty Lou Christie, the Minister's Patient Family Advisory Council Chair, who will share with us the importance of co-design. Welcome. As you join today's session, don't forget to select all panelists and attendees and introduce yourself in the chat box. We'd love to see who's here today. Hello, Arun. Welcome from Home and Community Care. Hi, Allison. Thank you for joining us today, representing VON. Yes, involved in many OHTs. Thank you for joining. Please also feel free to share your Twitter handle or email so you can continue your conversations beyond today. We will also share a summary with you, including the emails you share in the chat box following today's session. Ours is posted on the slides so you can stay up to date on RISE events and resources. Following the session, we'll also share a recording of this webinar, the deck, and a one-page summary with key highlights. Welcome, Caitlin. Thank you for joining. Good afternoon. Hi. Welcome, Jennifer. Thanks for joining, Primary Care Advisor from OH Central. Great to see you here today. Hi, Marjorie from East Toronto Health Partners and Carol from Mississauga Health. Hi, Lynn from Rivers. Welcome today. We also will have discussion periods throughout today's webinar, so feel free to add your questions to the chat box as we go through the presentation, and any resources you have found helpful, feel free to share those in the chat box too. All right, we are a few minutes in. We're getting close to the number of those who registered. So we will begin this session, but continue to introduce yourself to one another in the chat box and add your questions there as we go throughout the presentation. Before we start today's session, I would like to pass it over to one of our co-leads at RISE, Dr. Rob Reed. Rob, I think you're on mute.
Okay, there you go. Hi, everybody. It's Rob Reed here. I'm the Chief Scientist at Trillium Health Partners in Mississauga, and I also co-lead RISE, which is one of the Ontario Health Team supports to guide you through this journey. And it's so terrific to see so many of the names that I'm now recognizing from all across the province and all across all the OHTs. Welcome again. And I think today we've just got a terrific session for you. I've been looking forward to this session for a while, so I think you're going to be in for a treat. But before we start the webinar today, I'd like to acknowledge the land on which we work. As I work in Mississauga, we're using the Indigenous Traditional Land Acknowledgement Statement that was developed by the Indigenous people here in our region. And so as we meet here today, we are in solidarity with the Indigenous peoples of Turtle Island. And we'd like to begin by acknowledging the land on which we gather as part of the treaty lands and territory of the Mississaugas of the Credit, and before the traditional territory of the Haudenosaunee, Huron, and Wendat. We also acknowledge the many First Nations, Inuit, Métis, and other global Indigenous peoples who now call our area their home. We are grateful for the opportunity to work on this land. Land acknowledgements offer a moment to reflect on our responsibilities as guests on Indigenous territory. And in that spirit, I'd also like to recognize the now over 400 children identified in unmarked graves across Canada, those children yet to be discovered, and those all affected by the residential school system. We'd also like to acknowledge the family and community devastated by the act of hate against the Muslim community in London last week, and the continuing impacts of racism in many of our communities. We extend our deepest condolences to these communities and all those affected by these tragic and racist events. We want to take this opportunity to share our commitment to work together to take action against racism, and particularly how it influences health and well-being across Ontario. So before we start today, I'd like us to join in a moment of silence to collectively pay our respects and honor these communities by reflecting on what's taken place and how we can all affect positive change. Okay, let's start. And Leslie, if you could move to the next slide here. So today, I just mentioned this exciting day today. We've got three really powerful presentations, and I'm going to step off very quickly so we can hear from our guests. But today is all around looking at equity. And we're going to hear some examples around how to understand inequities in care in populations, and then time understanding how to leverage community resources to learn more about inequities and about how to work with marginalized communities. And we're going to learn some methods today on how to map OHT resources to support this work. And then finally, we're going to begin our journey around understanding the importance of patient engagement across this full spectrum of diversity in OHTs. Slide, Leslie. This slide is just to remind you of where our journey is in the population health management series that RISE is putting on. We have been, walking through this diagram, segmentation, co-design, implementation, and monitoring and evaluation. So you're getting used to this framework around population health management now. And today we are actually spending a little time now digging into equity. And equity is social factors in equity affect all parts of this diagram here and each segment of your population. So it is not its own separate part here. This is a cross-cutting theme that we have to apply across all of our work. So I'm gonna stop here, and I'm going to enter our first speaker, which is Cynthia. And Cynthia, if you can just wave at everybody here. Cynthia Daba is from Ontario Health. Cynthia is the manager for health analytics, and she's been working particularly with the Toronto region around their equity plan. and their equity strategy. And she's just got a terrific presentation, and I'm going to hand it straight over to Cynthia.
Thank you, Rob. Good afternoon, everyone. I'm happy to be here to present on this important topic. I think we're all familiar with the definition of health equity, which is the absence of unfair and avoidable differences in health, healthcare access, quality, and outcomes across populations. It is a broad subject which cannot be tackled in a few minutes, so I'll provide a high-level overview using examples. I have included extra slides in the appendix with additional information on equity and lists of resources. So health equity is a priority for the Toronto region, given a very diverse population who use our services. It has been embedded in the region's strategic plans, and more recently, it's being revitalized in the Toronto region anti-racism framework, which you can see on the left side. This work is aligned with the Ontario Health Equities Inclusion, Diversity and Anti-Racism Framework, which is the circle on the right. And as part of this work, Ontario Health has established a Black Health Plan working group to address disparities experienced by Black population in Toronto. But further details will be coming out on the different aspects you see on there. Ontario Health recognizes the importance of initiating equity data collection and is working to establish a standardized approach across the province to ensure consistency, comparability, and quality of the data. Providers and Ontario Health teams outside the Toronto region who have not started collecting equity data as yet are encouraged to use other methods such as what you'll hear today, and for example, using the Ontario Marginalization Index and other variables to measure health disparities in your populations and catchment areas. Next slide, please. The COVID pandemic has highlighted the importance of equity and socio-demographic data. Toronto Public Health data has showed that 3/4 of people affected with COVID in our city were racialized. In the top graph, you can see that the different groups such as South Asians, Latin Americans, Southeast Asians, Blacks, have blue bars that are higher than the green bars, indicating that they are disproportionately represented in the COVID cases compared to their share of the population. The lower graph shows a clear gradient of COVID hospitalizations by income. People with household incomes of less than 30,000 are 7.6 times higher chance of being hospitalized compared to those in the highest income group of 150,000 or more. We incorporated this knowledge in our data analysis to identify high needs neighborhoods or hotspot areas for COVID testing that you can see in the map. We selected neighborhoods that had high rates of COVID as well as high racialized groups and high prevalence of low income using census data. Toronto Public Health and Toronto Region as well worked with the Ontario Health teams and community partners to set up pop-up testing and supports related to social determinants of health. This analysis has also informed prioritizing neighborhoods for vaccine rollout, which you all are all familiar with. As we talk about equity and see diverse and adverse health outcomes linked to specific groups, it's important to remember that it's not the characteristics of these groups, such as being Black, that lead to the outcomes, but rather the historical, systemic, and structural inequities, such as racism, that these groups have faced that lead to these outcomes. So it's important to remember that when looking at strategies. Next slide, please. Like many cities, Toronto has a high number of homeless population, and I believe there are some odds that have selected this group as a priority population. Using an equity lens can help to better understand the diversity of these populations so that you can target appropriate supports and strategies to improve their outcomes. This information from the street needs assessment report showed much diversity among homeless in Toronto. Indigenous, racialized groups, LGBTQ youth and veterans were overrepresented. There was also a high disease burden, and nearly 1/3 having mental health issues, 31 having chronic or acute medical conditions. In addition, there was higher use of healthcare system, repeat ED and hospitalizations. So it is important to engage the different groups to understand their needs and the barriers they face. For example, the needs of the homeless LGBTQ youth will be different from those of Black immigrant families. Next slide, please. I have listed different types of socio-demographic data and sources available to inform your planning and the ways to analyze them. And I'll just touch on a couple of them. Remember, there are extra slides in the appendix with more information. An example of primary source of data would be the hospitals or CHCs collecting patient-level socio-demographic data for their clients. This type of data provides the most robust information as it is at patient level, and one can stratify indicators of interest for your priority populations by select variables to determine whether there are differential outcomes. For example, you can look to see if certain groups of seniors are experiencing higher rates of chronic conditions or higher rates of ED visits and admissions. For secondary sources, the census is a good source of secondary data, which can be used to understand diversity of people living in different areas. For example, in the odd catchment areas or neighborhoods or forward sortation areas. One can look at single characteristics such as income, education, visible minority groups, or you can use indices such as the Ontario Marginalization Index that has 4 different domains. I understand that HSPN has provided some odds with analysis of their indicators stratified by on-merge indices. Lastly, it's important to look at intersectionality where possible. This refers to the multiple and overlapping identities that individuals have. For example, an immigrant senior from the Caribbean will have different needs compared to an immigrant senior from, let's say, Southeast Asia. You can layer on other components like age, gender, and sexual orientation or disabilities. Next slide, please. In Toronto, hospitals and CHCs have been collecting equity data on their patients for many years. Those are the 8 standardized questions they collect, highlighted in purple, and there are also 4 optional questions which they can add as needed. Information about this project is available at the Toronto Health Equity website. There are also examples of how the providers have used the data and they collected. We also, hospitals also submitted their equity data to ICES to be linked to ICES databases and analyzed for key indicators on health status, health utilization, and health outcomes. And we saw large disparities in indicators. As I mentioned before, equity data collection in our region will be enhanced through the Toronto Region Anti-Racism Strategy, which is now in its implementation phase. Next slide, please. In terms of the uses of equity data, there are many, and I've touched on some of them already, but others are including informing direct clinical care, where they can be used to identify things like language needs or interpretation to help serve the patients better, or looking at cultural sensitivity of patients. The data are also important in quality improvement and can be used to profile who is being served by a particular program or Ontario Health team. They can be used to stratify equity indicators, as we've talked about, to determine where there are health disparities and who is most affected. And this information can be incorporated in quality improvement plans to address these disparities. Applying an equity lens can also be incorporated when Ontario Health teams are planning and designing care models. The disparities revealed can be used to modify the care pathways and informing the additional resources and supports required for a particular population and subgroup. Lastly, equity data can be used to evaluate interventions or strategies to determine if they're improving health and reducing disparities. If we look at overall averages, we may not see differences in some population subgroups. Next slide, please. This is my last slide. I just want to touch on the EGAP framework, which was developed to guide the collection, use, and management of race-based data from Black communities in ways that advance health equity. The concepts of this framework, which are engagement, governance, access, and protection, can also apply to other racialized groups or marginalized populations. For this presentation, I want to emphasize the importance of comprehensive engagement, which is moving towards a co-design process. It's essential to have an engagement process that involves broad consultation with affected community members, leaders, and organizations, not just limited to a few select individuals. It must be accessible at convenient times for the community. And the engagement should be genuine, and it must be continuous, not just one time, and be broad, involving all aspects of data collection, management, analysis, interpretation, and use. And you'll hear more about engaging the community through the next presentation. Thank you. That's my presentation.
Thanks so much, Cynthia. That was terrific. Remember, folks, we'll have a Q&A after Sophia presents, but feel free to type your questions into the chat, and I'll make sure that they get asked. I'd like to introduce Sophia Akira, who is the Executive Director of Health Commons Solutions Lab, who does absolute miracles with data, and she'll tell you more about how you can use your data and map your data.
Thanks so much, Mike. I just want to start by thanking Rob for really grounding our conversation today in a grave, but I think really important reminder of why we who are responsible for public health services and the delivery have to do a better job in really bridging those equity divides. And you know, I've worked with Cynthia for years. She's been championing equity data collection for, I think, over a decade, as long as I've worked with her. And we're seeing some real strides. So it's exciting to see these pieces coming together. And we want to thank you for the opportunity to speak today. I'm going to introduce my colleague, Zawar Patel, who's actually going to be providing the majority of the presentation. But just very quickly, I'm going to give an overview of Health Commons Solutions Lab. We are a publicly funded innovation lab. We're housed at Sinai. And the work that we do is really aimed at trying to support the system in doing exactly what Cynthia has described, which is first starting with data to understand where there are gaps in equity in the system, and then to think about how engagement and partnership can really help us to close equity gaps in our system and improve health outcomes for the whole population, but in particular those who have historically been left behind by our systems. So we use a variety of different approaches. We have some epidemiologists and health policy staff. We've also got some service designers. We use anthropologists in our work. And it does help us to get a pretty broad picture of health in the community, and then to really work closely with communities to understand what they're looking for and what they need so that we can advance their health goals. So today we're going to talk about how we use asset mapping as actually an equity exercise, really understanding the needs of the populations that we're working at, and helping to understand sort of the details and the color of what they need from our systems. So I'm going to hand it off to Zawar to speak to some specific examples of how we do this.
Hi, good afternoon, everyone. I'm Zawar Patel. Really nice to meet you all and have the opportunity to talk to you about asset mapping. So just really with this slide, what we're trying to do is to ask, when we're thinking about our priority populations, what do we know about the people who are benefiting from services today? So based on geography, demographics, race, and from a socioeconomic perspective, and who might be missing. And alongside this equity data, I think it's just remembering that it's important to understand assets in the community from the perspective of users. And by assets, not just formal services, but all of the resources that people access for their health and wellness. And thinking about assets in this way recognizes that equitable care is about respecting and responding to the experiences of people in their lives. And we'll just move on to give you a description of asset mapping and then a specific example. And so what we have with asset mapping is a really practical way of considering people's experiences. And there are different approaches to asset mapping, and we'll introduce you to some of those, and you can explore them in more detail later. And you could choose an example of asset mapping or an approach to asset mapping, depending on the type of problem you're trying to solve. For example, one approach looks at the capacity in an Ontario health team, and it's particularly relevant when first scoping the assets that you have when you're tackling a priority population. You can create an inventory of resources covering both organizations and services and generate an asset map that teams can refer to. Then there's another approach that maps connections between assets to look at how clients navigate both services and resources in their neighborhood. And then there's a third approach involving bringing people together, end users and providers, to co-design an asset map. And this helps providers to listen to diverse views that they may otherwise miss. And today we're going to talk to you about asset mapping as an engagement as an example of asset mapping. Next slide, please, Leslie. And so East Toronto, I just want to introduce this example from asset mapping as engagement from Toronto. East Toronto Health Partners were interested in finding out more about where youth go when seeking mental health and wellness supports. So we worked with them to bring together local youth and providers, and East Toronto Health Partners hosted the workshop. Participants worked together to identify local assets and key information about those assets. Information that was collected in the workshop was used to generate a map that could inform local planning. And we'll just talk you through the steps to this process. Next slide, please, Leslie. And so what we did at the workshop was to look at issues from the perspective of the individuals seeking help, to try to understand what they find easy and more challenging when accessing resources. And we developed examples of people's stories and journeys and asked participants to map in what they knew about where people go for support at different stages of their healthcare journey. And this provided a picture of system navigation that included more than just formal healthcare assets. And interestingly, before we did this exercise, we asked providers about assets, and they came up with around 40 or 50 examples of assets. And after we brought the providers and youth together, they identified over 300 assets to map onto these journeys. And when we focused in, the youth identified assets that were important from their perspective. It gave a much richer and more informative picture of what they considered to be an asset. So this included services and resources outside of the formal healthcare system. And from this, we can see that asset mapping is great for giving people the chance to describe what they need and what they want, where they go, and the system supports that they seek to stay healthy and well. If we just move on to the next slide. And when we generated the information on assets, we used that information to create an asset map and provide more information about those assets to help clients and providers. So alongside contact details and the types of services provided, youth were particularly interested in other issues such as whether Wi-Fi was available, if the service was accessible by transit, if food was available, and if their parents needed to know if they were there. Just moving on to the next slide. I apologize for skipping through these. We haven't got a huge amount of time, and we wanted to give you a flavor of what's going on and give you the opportunity to explore them in more detail later. And so just moving on to the next slide. When we were conducting this exercise, we developed this tool to find out more about what youth and providers wanted to know about a particular asset. And we used data gathered from this exercise and organized it into a list of most commonly requested information. And you know, when we think about accessing services, we all think about features that are important to us. And for example, if we think about testing sites or vaccine clinics at the moment, lots of people want to know about the type of vaccine that's available, for example. And while other issues may be important for other people, is their privacy. Can someone take a child with them if they don't have childcare, and so on. So it's the richness of, you know, people thinking about those resources that helps us to understand what's going to be important to them. And in this way, we can really start to think about grounding assets and resources from the perspective of the end user. Okay, next slide, please, Leslie. Okay, and I'm just going to make a couple of points before I hand back to Sophie to share some more insights with us. And so we can also take asset mapping to the next level. End users, clients have lots of ideas about adding more color and depth to the asset map. For example, using social media to reach out to youth with information and to gather feedback. And often people who use services think differently to providers about what the best information to include is. And by crowdsourcing the information and giving end users, clients, control over keeping it up to date, asset mapping can provide a real richness to information in considering equity for populations. And also, I think as a bonus, not be a burden on administrative resources for creating a map and keeping it up to date. Really empowering communities and populations to take control of this can generate partnerships with providers and with Ontario health teams and really give insightful knowledge in how to ensure equity for priority populations. So again, apologies for running through those slides. I'll hand back to Sophie to share some more insights with us before we conclude. Thank you.
Zawar, I thought that was a really great and rich picture of, how asset mapping can be used. And we've done, exercises like this, but for different populations. And every time we're surprised by what people bring forward as an asset that they've identified in their community. We worked with seniors to look at their neighborhood and the spaces around them. They identified things like, the grocery store where there's a Mandarin speaking person, or the pharmacy with the cheapest compression socks, like things that providers would not necessarily identify and actually would be very difficult for them to be able to maintain. So I think what Zawar's mentioned here, which is we have now the tools to crowdsource, maintain, update really rich pictures of the assets that are available in community. And I think one of the key features of that is how far outside of our formal system many of those assets track, and why it's important for us to think about those places and spaces and organizations as partners in health. And so, as much as this is an asset mapping exercise, it's an engagement exercise, and it also broadens our thinking about who else may be part of the exercise of improving health outcomes for the populations we're working with. One last observation that I would say that I thought was really interesting is the experience of bringing end users and the service providers together was really revealing to us in the following way. We find that often we get entrenched in the same discussions for many, many hours and many meetings that really reflect, I think, providers' perspectives and needs. That's not a surprise. An example of this is when we separated the youth and the service providers to ask them to pull together, a prototype of what an asset map might look like. Maybe it was a directory or a map or something else. We found providers naturally organize themselves into a conversation about whether or not there should be a rating system. And so across the 5 tables, each provider table just naturally gravitated to that and a debate about the value of a rating system. That's where they spent all of their time. The youth, on the other hand, 4 or 5 tables that sat with the same exercise, each came up with a pretty dynamic idea about an app or a service or a web page that would allow them to quickly upload their information, provide reviews, share information with their peers. It was a much more robust picture. And so I think the opportunity here in some ways is to allow providers to leapfrog over some of the things that we get hung on and really allow the end user to sort of give us a bit of a steer on where we can go as service planners to best meet their needs. So it does help us sort of leapfrog over some of those things we get hung up on. We're going to leave it there. I think Zawar has one last slide. Just to share that, as I mentioned, we're a publicly funded organization, and we are here to support Ontario health teams alongside organizations like RISE. All of the tools that you've seen here are available on the website for download, and they come with instructions for how to do these things, but you can always reach out for further information if you're curious about how your Ontario health team might be able to pull together an exercise like this. So thanks so much for allowing us to share some of that.
Yeah, thanks very much.
Yes, wonderful. Thank you, Zawar and Sophia. We have a few minutes for question and answers. Marcia put a question in that she'd like the panel to comment on the reality that the absence of equity data and the absence of being able to map is often a convenient excuse to maintain the status quo and to not address health equity. They just wanted you to comment on that tendency.
I can go first.
Sure.
I think that's an important statement, and we do encourage everybody who's providing services to look at different methods of how to collect to use equity data. So it may be that you're not your organization is not collecting the equity data per se from their clients, but there are other ways that I've talked about where you can understand where your patients are coming. If you know where your patients are coming from, what areas or neighborhoods they're coming from, you can look at the sociodemographic characteristics in those neighborhoods, see what are the predominant groups, whether be it races, whether it's low income or type of education, whether they are more seniors or that. And you can use that information then to engage various groups. You engage the community itself in a meaningful way, like I talked about. You engage service providers, and then you also engage like community providers or even community organizations beyond health who have been serving those populations. So you have a comprehensive picture of what the barriers are, what their needs are, and you can incorporate that in your strategies. And I think Sophie has provided a good example of, those engagement processes and looking at asset map.
Yes, thank you, Cynthia. That was a great answer. Just a couple of reflections that I might add to it. I think like any very complex problem, we need multiple ways of sort of addressing that. So I think you're right that embedded in the question of why there's a lag on the collection of data are attitudes and beliefs that it's not important, maybe fears about what it would reveal. There's sometimes logistical challenges or operational challenges with doing it and storing it. But I think at the heart of it, the first step is to really, I think, get a group of very activated leaders who understand that from a strategic and sustainability perspective, we actually cannot afford to ignore the equity picture. We just can't afford to have a system that is not able to respond to those who have the greatest needs and come to our system most consistently, often too late. And so I think there's many leaders in the system who can be activated around that. And then once you have some leadership moving, you can use a top-down, bottom-up approach. So the top-down piece from my perspective, and I know there's many people here from Ontario Health, is setting the tone around the expectation that there will be meaningful and authentic engagement with the equity question across each of the Ontario Health teams. And I think the equity framework that's been designed by OH and is about to be rolled out will come along with some accountability measures. That often brings the other cohort of people who will do it because they're required to. But bottom up from inside organizations, the opportunity to get an early picture of what service looks like, who's getting access and who's not, is the reason for collecting the data at point of care. I would say right now is a really key opportunity, and I have to plug this, that we are in a moment where we have almost every person in the province coming through our healthcare system to get their vaccine. It's a critical opportunity in the second dose to record this information. And we have scripts that make the questions really easy to ask. It can be recorded in the COVAX system. So we're set up right now in a way that we have never been set up before to collect data en masse. And so if anybody is interested in seeing those scripts, the visual tools, it does make it very easy for people to collect this information at the point of care. I think it's a transformational opportunity for the system. And so I'm going to plug it now and share those resources afterwards. But I think that, just thinking through strategies to resolve the points of resistance in the system is really important.
We can't hear you, Rob.
So Mike, can I just add one thing? Because just to
Sure.
echo a couple just really important things that Cynthia and Sophie talked about there. First, Cynthia remarked around, you will not know about inequities unless you look, meaning you need to have data to look at that. And it takes courage and it takes commitment to gather the necessary data. But Cynthia has really shown that it is absolutely doable, absolutely doable. This is not a technical problem. This is a problem around shying away from this issue. So I'd encourage people to do this. And the second thing that Sophie really demonstrated is that we cannot apply a one-size-fits-all approach around care and care delivery. We actually have to take a user-centered approach clearly to address those equities, but you can't do it unless you know where those inequities exist.
Thanks, Rob. We have a lot of questions. If we don't get to all of them, we will answer them after the presentation. The next question was from Allison. It said, it'd be interesting to understand the informal versus formal types of supports that people use. How can we maximize or optimize those informal supports because they would help build networking and system capacity?
Yeah, I think, so I can speak to that. I think, the first opportunity is just to ask people to map what they use. So often we use patient journeys and, we have a couple of samples, for different populations, youth, people with mental health and addictions issues, seniors navigating the system. And if you put the journey in front of people, it has, key points of, what's changing in their journey. And they'll fill in the rest. And so they'll tell you everything on the formal side and the informal side that they're accessing. Formal service providers can also share that picture with you. I think the next piece is just revealing what that looks like. And then I think it's key to try and understand which patterns of access are repeated. So that might point to a really important partnership that you don't have in place that you might want to foster as an Ontario Health team. But often just, I think, revealing that those resources are there is an important way of informing the end user or the client or the patient of what's available in their community, and sharing it with service providers broadly so they also understand what else is around them in terms of resources that they can tap when they're serving patients' needs.
Thanks, Cynthia. Time for one more. Frank has asked, he starts off with great presentations. By the way, the chat is filled with how wonderful people thought your presentations are. He's asking, has there been a determination of a standardized health equity data collection tool that would be adapted across sectors and across OHTs? We're in the process of exploring the feasibility of having providers in the OHT and collect the same HE data, but we would like to, we would like to align with other OHTs if that's what's happening.
Yeah, so I can answer that. And there is discussions and work happening currently at Ontario Health, the work that is led by Anna Greenberg, to look at a standardized way of rolling out equity data collection across our providers and Ontario Health teams across the province. In the Toronto region, so more information will be forthcoming to the regions and to the organizations. In the meantime, we know that some organizations have already started collecting equity data, and that is encouraged to continue. And we'll see how to tailor it and standardize it once more directions come. At Toronto region, we have the health equity data collection, the Measuring Health Equity project I talked about for hospitals and CHCs. And we are revitalizing that through our anti-racism strategy. We have collected a broad list of resources and tools that can be used for those 4 pillars that I showed, one including equity data, one being equity data collection. This is going to be rolled out. We're just planning the implementation phase, first looking at a group of early adopters to look at these tools, put some more refinement around how to guide people in using the tools for all these things around anti-racism training, data collection, and all use of the data for accountability and stuff. And this, once that pilot is done, it will be rolled out to other sectors of the healthcare system. So more information is coming, and Frank, you can reach out to me. I can provide more information or link you to Ontario Health.
Great. Thank you so much, Cynthia. Yeah, very quickly, Sophia.
Very quickly. We do have a resource for anybody that's interested in rolling out equity data collection through the second dose vaccination program. It includes the questions that can be asked with script and visual aids. And so we'd like to share that with the group in case there's an opportunity to begin equity data collection now.
Wonderful. And we'll collect all those tools, everyone, and we'll make sure we share them through the online forum as well as a presentation. Thank you, Cynthia, Sophia, and Zawar. Rob, do you want to introduce our next speaker?
Sure, and I'm just terrifically happy to introduce Betty Lou Christie, who's joining us today. Betty Lou, as many of you have I think met Betty Lou before on part of the Ministry of Health's webinar series. Betty Lou is the chair of the Minister's Patient and Family Advisory Council. This is going to be our first introduction to Betty Lou, and you're going to be hearing more from Betty Lou later in some of our next sessions. But today we thought it was really important to anchor this discussion around equity, around actually patients and families, because that at the end of the day is where this is. So Betty Lou, I'll give it over to you.
Great, thank you. I'm just putting my timer on, and Leslie, next slide, please. So I'm just going to hit I'm going to go at warp speed. I'm only going to do a deep dive on one slide, but the importance of co-designing with patients, families, and caregivers. And I want to add the caveat that when I'm talking about patients, I'm also speaking to lived and living experience and people who identify as residents and citizens, so we can be inclusive of all the names that we identify by. So the co-design with patients, families, and caregivers focuses on its building relationships and its linkages to provincial expertise, systems governance, policy, and planning that create and impact the health ecosystem for the authentic engagement of lived and family experience. The rationale and the reasons why I've seen play out for the last 20 years, it reduces duplications, inefficiencies, barriers and silos, what I call noise and chaos in the world of when we're trying to go to systems and get services. It creates opportunities to share knowledge, expertise, and evidence, however that is identified and whomever that is coming from. It is foundational to co-creation, humanizing, and equity. Solidifies the partnerships and infrastructure needed for sustainability, and it promotes the recognition and integration of patients, families, caregivers as a viable and valued part of person-directed healthcare. Next slide. What I've often found from being in the community provider, and particularly the mental health, substance use, and/or addiction, is that the clinical medical models for data collection and outcome measurements, work plans, product chargers, they're not necessarily an ideal fit with the true organic nature of values-based and the intention of engaging people using services and what truly matters to people who are engaging services. And in order to be responsive to existing system needs, the entire approach to co-design has to be about bridging. It's about bridging that qualitative, quantitative, experience-based co-design, human-centered design, experiential knowledge, and expertise. Next slide. The biggest thing I've also found in my journey and is really, it's part of a larger system, and there's so many spheres of influence. But person-directed care and services is all about its bridging dynamic, complex systems. It's hard to change a system. It's about partnering and collaborating. It's also about networks and networking, which is often looked at as a soft skill. And let me tell you that's one of the most important pieces. Next slide. What's really important is the focus on relationships and shared voice. So once again, it's relationship building. It's that shared voice. It's that larger group vision in that we collectively have to decide what is our North Star? What is important to us? Where are we trying to strive for? And have agreements on that. How we get there may look different, but that's really, really important. Next slide. So the transformation of the healthcare system is complex and dynamic. So obviously building capacity, relationships, once again, relationships. Responsive care enhances the healthcare system and lessens the burdens across many demographics. Developing intentional engagement is integral to system change, and it has the ability to augment care provision. It's more about a culture shift. It's more about social change as much as it is about quotation marks medicine. Next slide. So I really live and breathe values and how you convert those values into behavior so you can measure them. Values I found has been the foundational basis for moving everything forward that I've personally been involved with. So values are the core essence of the work. Translating values into actions has provided a basis for training, evaluation, quality improvement, and a common language to communicate how to stay authentic. Knowing that the human connection is the most important part of treatment and support, being able to translate and hold people accountable to actual values and action in interactions with an individual is absolutely vital. Next slide. And what I've seen transition over the last 15, 20 years in the roles that I've played from the lived experience, family caregiver experience perspective, is that it actually honors the person holistically. It honors the person as an expert in their own lived experience. It empowers the person to achieve their self-defined wellness goals. It reminds the person that they have innate, unwavering worth, and it creates a space where safety and self-exploration can occur. Next slide. So this one, can you tell this is my government slide because it's got so much information on it? This is the one I'm going to take a deeper dive on. So as we know, the Ontario Health Teams model is a truly transformational initiative that is rooted in a number of foundational pillars. Central to this work, teams are to uphold the principles of patient partnership, community engagement, and system co-design, and meaningful engagement with partners with patients, families, caregivers, and communities. So through these efforts, teams will be able to more meaningfully and effectively design care in ways that best meet the needs of the populations they serve in the planning, design, delivery, and evaluation of services. As a first step, approved Ontario Health Teams have been asked to create a patient, family, and caregiver partnership and engagement strategy. They will also confirm a patient declaration of values aligned to the Ontario Declaration. Both of these foundational documents will guide OHT work based on values and principles, with co-design at the center and an equity lens considered throughout. Upon review of the patient, family, caregiver partnership and engagement strategy guidance document, only the government can have something that's so long a name, you'll note that a number of suggested principles were set out for teams to align with as they begin to embark, and these include partnership and co-design, learning, empowerment, transparency, responsiveness, and respect. A common element across all of these principles is that they have an equity lens embedded in them and support inclusion of diverse communities. This should be a key takeaway. The guidance document also identifies a number of key enablers that OHTs can leverage to ensure meaningful partnership and co-design with patients, families, and caregivers from their local populations. These include a commitment to diversity, inclusion, health equity and cultural competence, and minimizing barriers. While everyone is starting from a different starting point, some with long histories of meaningful and robust partnership, and some just learning how to engage patients, families, and caregivers at a broader system level, equity considerations are paramount as teams undertake their work. As we look to the road ahead, I think there's a great opportunity to learn from the successes of teams that have found a way to truly build effective patient partnership and community engagement into the core of their Ontario Health Teams work and spread those learnings across teams. Next slide. And this is my second last slide, and I'll be closing up. This is really important to me. This is something I landed quite a while ago, and it resonates, and it's kind of like my North Star, is that when allowed full and equitable political and social power with meaningful involvement in healthcare, governance, policy, development, planning, delivery, and evaluation, people with lived and living experience, family and caregivers, and peers can provide unique and relevant context upon which to work with and base decisions on. The lived experience of people, families, caregivers, and peer support is shaping a cultural shift from storytelling to evidence. It provides a roadmap to affirmative change. And what comes from that is our personal journeys, equal living expertise, is experiential evidence. And the last slide, it's one of the most important things I've learned in my many, many years of advocacy, is that it's about all of us working together across the diverse populations. We all want the best healthcare possible for those we love and ourselves. Our system is always growing. It's hard to change a system. And my favorite saying always is do the best you can until you know better. Then when you know better, do better. Thanks very much.
And thank you, Betty. I mean, today that's just such a North Star for us all. And you know, it's always important that everything begins with patients, families, and caregiver, and everything ends with patients, families, and caregiver in our sector. That is the intent, and I think you echoed that really well. There were a few really key words that you used that we should always keep in mind: partnership, collaboration, empowerment, respect, accountability to our patients and families. And I hope everybody in the audience today can see the connections between all of the different presenters today. Clearly, Zawar and Sophie talked about the importance of engaging rich communities in the co-design work in an authentic way and empowering them to invent how we're going to design care in the future for them. Yeah, really mapped out the importance that it's not a one-size-fits-all approach. It is considering the diversity in needs, expectations, and preferences around different populations. So we have to end right now, I think, or pretty close. Betty Lou, we'll be inviting you back to the next session, and we'll have lots of time for questions from everybody. The next session is really around actually now, how do we do this co-design with patients, families, and caregivers? And we're going to get really into the meat of the co-design work. So you'll see that is on August 19th at 11:30. And then we are going to actually plan a work around Indigenous peoples, a special population that we really have to pay attention to. And so that work, we're going to be planning some work in September or October, so stay tuned for that. And everybody, we've got our coaches, everybody's got their coaches aligned. If you haven't got a coach yet, you want to get a coach, get a hold of Leslie and we'll map you onto it. But I think, Leslie, if that's okay, I just wanted to say thank you to all of our speakers today. This was just a fantastic session. I think we could have gone on for 3 hours talking about this. So thank you to Cynthia, Sophie, Zawar, and Betty Lou. Just tremendous. And then Mike and Leslie from our end, thank you as well.